Let me tell you about a guy I'll call Gerald. 72 years old, mind like a steel trap, retired, healthy, doing everything right. He walks into a hospital on a Tuesday for a scheduled procedure. Nothing dramatic, nothing life-threatening. His doctor told him it was routine, and Gerald had zero reason to doubt that. He shows up, checks in, the nurses smile, they hand him a stack of papers, he signs them. Because what else are you going to do? You're in a hospital. You trust these people. You put your name on the dotted line, and you move on with your day. That is exactly what every single person does, and I'm not going to sit here and pretend I wouldn't do the same thing. 4 days go by. Gerald goes home. Recovers just fine. Everything looks normal. Then the mail starts coming. First bill. From a surgeon Gerald has never spoken to. Never shaken hands with. Never even laid eyes on. Some out-of-network specialist who apparently showed up during his procedure as an assistant. Nobody asked Gerald if that was okay. Nobody mentioned this person existed. But here's a bill with Gerald's name on it. Second bill. From the hospital itself. And this one's worse. Turns out Medicare isn't covering Gerald's stay the way he expected because, and this is the kicker, Gerald was never actually admitted to the hospital as an inpatient. He was there for 4 days. He had a bed. He ate hospital food. Nurses checked on him around the clock, but according to the paperwork, he was classified under something called observation status, which means, under Medicare's rules, he was technically an outpatient the entire time. And because of that single classification, Medicare won't pay for the rehabilitation facility his doctor said he needed after going home. Gerald didn't screw up. He asked questions. He followed instructions. He did what any reasonable person would do. But 5 pieces of critical information could have protected him, and nobody, not one person in that hospital, volunteered any of it. By the time Gerald figured out what had actually happened, his window to fight it had already closed. I'm Dr. William Parker. 21 years in senior health. And what I'm going to break down for you right now are 7 traps, not 5, 7, that the hospital and Medicare system sets for seniors every single year. Not because seniors are stupid, not because they're careless, because the system is deliberately complicated and nobody bothers to explain the rules until you've already been burned by them. I need you to stick with me through all 7. Trap number 4 is something almost nobody thinks to ask about. Trap number 5, the observation status nightmare, is the single most expensive mistake I cover on this entire channel. And traps 6 and 7 are ones I've added because I keep seeing them destroy people financially and emotionally, and I'm done watching it happen in silence. If you're new here, hit subscribe right now. This channel exists for one purpose: giving adults straightforward, no-nonsense guidance so you understand how this system works before it makes decisions for you. No fluff. No scare tactics. Just the information you need. Let's get into it. The framework you need first before I hit you with the traps. You need to understand one concept. I call it the assumption gap. Without it, the individual traps are just isolated facts. With it, the whole picture snaps into focus. Here's what fundamentally shifts about your relationship with the healthcare system after you turn 65. 3 things. Number 1, the rules get harder, not easier. Most people walk into Medicare thinking coverage is simple now. Government insurance, right? How complicated can it be? The answer is brutally complicated. Medicare's regulations around hospital stays, observation status, rehabilitation eligibility, and post-acute care are some of the most convoluted rules in the entire American healthcare system. If you don't understand them, you will pay for that ignorance. Literally. Number 2, the forms you sign actually matter in ways nobody tells you. Hospital admission documents are not just consent to treatment paperwork. They contain financial clauses, legal language, liability transfers, and most hospital employees will never walk you through what those clauses actually say. When you put your signature on that paper without reading it, you are potentially handing the hospital permission to come after you for costs that you could have otherwise fought. Number 3, and this is the big one that ties everything together, The hospital system and the insurance system are designed to protect their own interests, not yours. I'm not calling anyone evil. I'm telling you how the incentives are structured. Hospitals get paid based on how they classify your stay. Insurers save money by denying coverage whenever the rules allow it. You, the patient, are sitting in the middle of two systems that are both optimizing for their own bottom line. Nobody in that equation is optimizing for yours unless you force them to. The assumption gap is the distance between what you think your coverage includes and what it actually includes under the specific circumstances of your stay. Every single trap on today's list lives inside that gap, and the gap is wide. It's wider than most people realize until they're standing in the middle of it, holding a bill they can't afford, wondering how things went sideways when they did everything they were supposed to do. I've seen it with engineers, with former executives, with retired professors, brilliant people who navigated complicated careers without breaking a sweat, completely blindsided by a system that punishes you for not knowing rules that nobody taught you. Intelligence doesn't protect you here. Preparation does. Keep that framework in your head as we go through each trap. Now let me ask you something real. Think about the last time you or someone you care about dealt with a hospital. Remember how fast everything moved? Somebody shoved a clipboard at you. Pages and pages of tiny print. You had maybe 90 seconds to look at it while a nurse was waiting and your blood pressure was being taken, and you were worried about the actual medical thing happening to you. You signed it. Of course you signed it. Everyone signs it. Nobody stopped the process and said, "Hold on, here are 7 things you need to understand before you agree to any of this." That conversation does not happen. It has never happened. And it probably never will, unless you make it happen yourself. That's what this video is for. The financial disasters that follow hospital stays for people over 65 are not random bad luck. They are predictable. They are preventable. And they are preventable specifically because the rights and protections already exist. Most people just don't know about them until it's too late. Not fear, not doom. Practical knowledge that puts you in the driver's seat. Quick thing, if you want all of this written down in one document you can print out and keep in a folder, I've got a free resource linked in the description. It's called the Longevity Guide. Thousands of people in this community already have it. Grab it now and follow along. If any of this is landing with you so far, do me a favor, smash that like button, drop a comment telling me where you're watching from, and subscribe if you haven't already. It takes 2 seconds and it helps more people find this information. How the two systems work against you. Let me pull back the curtain on something most people never see. When you show up at a hospital, 2 completely separate machines start running at the same time. Machine 1 is the clinical side. Doctors, nurses, treatments, medications. This machine cares about your health. It's trying to fix whatever brought you in. Machine 2 is the administrative side. Billing codes, insurance classifications, payment categories. This machine cares about money. It's trying to figure out how your stay gets categorized for reimbursement purposes. Here's the problem. These 2 machines barely talk to each other, and the classification that Machine 2 assigns to your stay, often within the first few hours you're there, can determine whether you owe $500 or $50,000 when it's all over. I use this analogy all the time. Imagine checking into a hotel. You walk up to the front desk. Depending on whether the receptionist logs you as a regular guest or a conference attendee, your rate changes. The services included in your bill change. You're sleeping in the same bed. You're eating the same eggs at breakfast. But what you pay is completely different based on a classification you never asked about and nobody explained. That is the hospital system in a nutshell. Same bed, same nurses, same IV drip, radically different bill based on how someone behind a computer decided to categorize your presence. The Office of the Inspector General put out a report showing that Medicare patients placed under observation status, instead of being formally admitted, paid an average of $7,000 more out of pocket per hospital stay compared to those who were admitted as inpatients. $7 grand. Not because they got worse care, not because they stayed longer, because of a classification they didn't know existed. That's not a glitch. That's the system doing exactly what it was built to do. In 21 years of working in this space, I've identified 7 specific traps inside this system that hit seniors the hardest and the most often. I've ordered them deliberately, common stuff first, most devastating stuff last. The final 3 are where the real money is. But you need the first 4 to understand why the last 3 hit so hard. Let's go. Trap 1. Out-of-network surprise bills Barbara. 68. Good Medicare coverage. Carried a supplemental plan for years. She needed a cardiac procedure and she did her homework. Picked an in-network hospital. Confirmed her primary surgeon was in-network. Asked the questions she thought she was supposed to ask. 3 weeks after the procedure, a bill shows up for over $4,000 from an anesthesiologist she'd never heard of, never chosen, never been told about. This person assisted during her procedure and happened to be out of her insurance network. Here's the blunt truth. If your hospital and your lead surgeon are in network, that does not mean every human being who touches you during your procedure is also in network. Hospitals use contract specialists all the time. Anesthesiologists, radiologists, pathologists, surgical assistants, and these people maintain their own separate network agreements. They bill independently. The hospital's in-network status does not automatically extend to them. Period. Now, the No Surprises Act went into effect in January 2022, and it does offer real protection here. For most planned procedures, out-of-network providers cannot charge you more than your in-network cost-sharing rate unless you've given explicit written consent in advance. That word explicit is doing a lot of heavy lifting. Because if you sign a general consent form that happens to include a clause waiving your No Surprises Act protections buried on page 4 in 8-point font, that waiver can stick. What do you actually do about this? Before any planned procedure, ask the hospital, in writing, for a complete list of every provider who will be involved in your care. Ask which of those providers are in your insurance network. If any are out of network, ask whether you can request an in-network substitute. And if someone puts a form in front of you that mentions financial responsibility or non-participating provider, read that section word by word before you sign. If you get hit with a surprise bill after the fact, you've got rights. The No Surprises Act dispute process runs through CMS, the Centers for Medicare and Medicaid Services, and your insurer is legally required to tell you how to start it. Within 30 days of receiving a bill you think is wrong, contact your insurer, demand an itemized statement, and document every conversation. Dates, names, what was said. The earlier you push back, the more leverage you have. The mistake people make is assuming a general consent form is just a formality. It's not. It's a legal document. Treat it like one. Trap 2. Getting kicked out too early. Harold, 74. Fell, cracked something in his hip. Admitted to the hospital. After 3 days, a hospital administrator, not his doctor, an administrator, tells Harold his insurance approved his stay through the following morning, and he should plan to leave. Harold still felt terrible. His pain was nowhere near under control. He was unsteady on his feet. But he figured if the insurance company said it was time to go, that must mean he was ready. So he went home. 2 days later, he fell again. Here's what Harold didn't know, and here's what kills me about this one. Medicare patients have the legal right to appeal a discharge decision before they leave the hospital. Same day if necessary. This is not a suggestion box. It is a federal right. It's called a KIO appeal, Quality Improvement Organization appeal. Every Medicare patient is supposed to receive a written document called the Important Message from Medicare before discharge. And that document explains this right. If you never received it, the hospital violated the rules. The Commonwealth Fund found that roughly 1 in 5 Medicare patients gets readmitted to the hospital within 30 days of discharge. Premature discharge is one of the most common reasons, and readmission creates its own avalanche of costs, complications, and coverage headaches. Here's what you do. If you or someone in your family feels that discharge is happening before it's medically safe, you pick up the phone and call the CHIO. The number is on that important message from Medicare document. You request a formal review. Medicare will continue paying for your stay while the appeal is being processed. The hospital cannot throw you out during that review period. You do not need a lawyer. You do not need your doctor's permission. The fatal mistake is waiting until you're already home to raise the concern. Once you've left, the appeal process changes dramatically, and your options shrink. You fight this battle before you walk out the door, not after. I cannot stress this enough. The moment someone says the word discharge, and you or your family member isn't comfortable with it, that is the moment you act. Not tomorrow. Not after you get home and feel bad. Right then and there. Have you or someone in your family ever felt that a hospital discharge happened too fast? Drop a yes or no in the comments. I guarantee you the responses are going to be overwhelming, because this happens constantly, and most people only find out they had options after those options have expired. Real quick, if you're still with me, you're already ahead of 95% of people who deal with hospitals. Like this video. Share it with someone who needs it. And subscribe so you don't miss what's coming next, because it gets worse. Trap 3. Medication swaps you never agreed to. Ruth, 71. Takes 4 medications every day, each one carefully selected and adjusted by her doctor over several years. She goes in for a knee replacement, and the hospital swaps 2 of her meds for alternatives from their own formulary, which is basically the hospital's approved shopping list of drugs. Nobody asked Ruth. Nobody explained why. She assumed the hospital knew what it was doing. After she went home, she started having side effects she'd never experienced before. It took 2 months of working with her doctor to get her regimen back to normal. This is standard practice, and that's exactly the problem. Hospitals keep their own drug lists, and when your regular medication isn't on that list, they substitute something they consider equivalent. They're legally allowed to do this based on the general admission consent you signed. But equivalent on paper and equivalent in your body are 2 very different things, especially when you're over 65 and taking multiple medications that interact with each other. The American Journal of Health System Pharmacy published data showing that medication discrepancies at hospital admission affected a huge portion of older adults, particularly those on 5 or more drugs, and that these discrepancies were a leading cause of adverse drug events during and after hospitalization. What to do before any planned hospital stay: write out every single medication you take, drug name, dose, frequency, include over-the-counter stuff and supplements. Bring that list. Hand it to your care team on arrival and ask point blank, will any of these be substituted during my stay? If yes, why? And can my regular doctor be consulted before you make any changes? You have every right to ask these questions. You have every right to involve your own physician. The mistake is assuming the hospital pharmacy is automatically coordinating with your personal doctor. In a startling number of cases, they're not. That coordination falls on you. This isn't medical advice. Your specific situation requires your own physician's judgment. But the habit of bringing a written medication list to every hospital encounter is one of the single most protective things you can do for yourself. Trap 4. Financial landmines hiding in admission paperwork. Now, we're getting into the territory that genuinely makes me angry. This is where the system stops being accidentally confusing and starts feeling deliberately predatory. Martin, 69, comes in through the emergency department after a cardiac event. He's scared. He's in pain. He's not in any condition to sit there reading legal documents. So he signs everything they put in front of him. Fast, without reading. Buried in that stack was a clause where Martin agreed to be financially responsible for any charges his insurance didn't cover, including charges resulting from coverage disputes. 18 months later, when his insurer denied part of his claim, the hospital pulled out that signed document and used it to come after Martin directly for the balance. The Kaiser Family Foundation found that more than half of American adults reported difficulty affording healthcare costs, with surprise billing and unexpected charges being the most common sources of financial pain. For seniors living on fixed incomes, one unexpected hospital bill can represent 3, 4, 5 months of income. Here's the play. If you have any capacity at all to review admission paperwork, or if a family member or friend is with you, look for specific phrases: financial responsibility, assignment of benefits, non-covered charges. These are the clauses that can hurt you. You are allowed to ask questions before you sign. You are allowed to physically cross out a clause you don't agree with. Write, "I do not consent to this section," and initial it. Does that guarantee the hospital will honor your annotation? No. But it creates a documented record of your objection that becomes extremely useful if you end up in a billing dispute later. If you came in through the emergency department and couldn't review anything in advance, you can request a copy of everything you signed once you're stable. And you absolutely have the right to dispute charges that came from clauses you were in no position to understand when you signed. The mistake is thinking that because you signed something while you were scared and in pain, you're stuck with whatever it says. That's not always true. A lot of billing disputes get resolved after the fact, but they require documentation and they require you to actually fight. All right, we're past the halfway point and the heaviest stuff is still coming. If you're learning things you didn't know before, hit like right now. Drop a comment, have you ever felt rushed through hospital paperwork? And if you haven't subscribed yet, what are you waiting for? This stuff could save you or your family thousands of dollars. Trap 5. Observation status versus inpatient admission. This is it. The big one. The trap that connects directly back to Gerald's story, and the one that has probably cost American seniors more money than any other single classification in the entire Medicare system. When you show up at a hospital and a doctor decides you need to stay, you and everyone with you will assume you've been admitted as an inpatient. That seems obvious. You have a bed. You have a wristband. Nurses are checking your vitals every few hours. You're in the hospital. Of course you've been admitted. In an enormous number of cases, you have not been admitted. You've been placed under observation status, which means, according to Medicare's rules, you are technically an outpatient who happens to be receiving extended monitoring inside a hospital. You're in a hospital bed. You might be there for 3, 4, even 5 days, but on paper, you're an outpatient. The financial difference is staggering, and it is not an exaggeration to call it life-altering for some people. Under Medicare Part A, a legitimate inpatient admission covers your hospital stay. More importantly, it makes you eligible for post-acute rehabilitation at a skilled nursing facility, but only if you meet the 3-day inpatient stay requirement. Under observation status, none of that kicks in. Your stay gets billed under Medicare Part B instead of Part A, usually at higher out-of-pocket costs. And you are completely ineligible for covered skilled nursing facility care, no matter how many days you physically spent inside that hospital. The Government Accountability Office found that the number of Medicare beneficiaries placed under observation status for more than 48 hours increased by over 96% between 2006 and 2014. Many of those patients had absolutely no idea about their classification until the bills arrived. People who needed rehabilitation care after their hospital stay got hit with skilled nursing facility costs of $500 or more per day, costs Medicare would have covered if they'd been classified as inpatients. There is a law, the Notice Act, that requires hospitals to tell Medicare patients in writing within 36 hours if they're under observation status. That written notification is called the MOON, Medicare Outpatient Observation Notice. You are legally entitled to receive it. If nobody gives you one, demand it. What you do, within the first 24 hours of any hospital stay, ask your nurse or care coordinator directly. Am I formally admitted as an inpatient, or am I under observation status? Write down the answer. Write down who told you. If the answer is observation status, and you believe your condition warrants inpatient admission, you or your physician can request a status review. Your doctor's clinical judgment about the appropriate level of care carries serious weight in that review. Ask on arrival. Ask again after 24 hours. If someone tells you inpatient admission needs authorization, ask who's responsible for getting that authorization and how long it's going to take. The most expensive mistake on this entire list, the one that has cost families hundreds of thousands of dollars, is assuming that if a hospital put you in a bed and kept you for 3 days, Medicare automatically counts those 3 days towards skilled nursing facility eligibility. That assumption is wrong. And by the time most people find out it's wrong, the damage is already done. The question costs you nothing. The answer can change everything. Trap 6. The discharge summary. Nobody reads this one, doesn't get talked about enough. And I'm adding it because I've personally watched it wreck people's recoveries. When you leave the hospital, you're supposed to receive a discharge summary. It's a document that outlines what happened during your stay, what medications you're going home with, what follow-up appointments you need, and what warning signs should send you back to the emergency room. This document is your bridge between hospital care and home care. It's critical. The problem? Most patients never read it. And in a disturbing number of cases, the discharge summary contains errors, wrong medication dosages, missing diagnoses, incorrect follow-up instructions. A study from the Journal of Hospital Medicine found that discharge summaries contained at least one clinically significant error in roughly 1 out of every 5 cases reviewed. That's not a rounding error. That's a systemic failure. And here's where it gets financially dangerous. If your discharge summary doesn't accurately reflect what happened during your stay, it can create problems with insurance claims, follow-up authorizations, and even readmission coverage. If your insurer's records don't match what your doctor documents next, you can end up in a bureaucratic nightmare trying to get coverage for care you actually need. What to do before you leave the hospital? Ask for your discharge summary. Read it. If something looks wrong, a medication dose that doesn't match, a diagnosis you don't recognize, a follow-up appointment that wasn't discussed, flag it immediately. Ask for a correction before you walk out. Bring that document to your first follow-up appointment with your regular doctor so they can review it and make sure the hospital's records match reality. The mistake is treating the discharge summary like junk mail. It's not. It's a medical and legal document that follows you into every future interaction with the healthcare system. Your next doctor reads it. Your insurer reads it. And if it's wrong, those errors compound. A wrong medication dose on paper can lead to a wrong prescription in practice. A missing diagnosis can mean a denied claim for follow-up care. 20 minutes of review before you leave the hospital can save you weeks of phone calls and appeals later. I've seen people lose coverage for follow-up procedures because the discharge summary didn't mention a condition that was discussed verbally during the stay. If it's not written down, it doesn't exist as far as the insurance company is concerned. Protect yourself by making sure the paper trail matches reality. We're in the home stretch now. Traps 6 and 7 are the ones I added because I see them constantly and nobody else is talking about them. Like, comment, subscribe, and share this with anyone over 60 in your life. Seriously, this information is too important to keep to yourself. Trap 7. The rehabilitation denial you didn't see coming. This trap is a direct downstream consequence of Trap 5. And it deserves its own section because the devastation it causes is on another level. Let's say you cleared the observation status hurdle. You were formally admitted as an inpatient. You had your 3 qualifying days. Your doctor recommends a skilled nursing facility for rehabilitation. You think you're covered. Then Medicare denies the rehabilitation stay. Why? Because Medicare doesn't just require 3 inpatient days. It also requires that the rehabilitation services be skilled, meaning they require the expertise of licensed professionals and can't be performed by non-professionals. If Medicare's reviewers decide that your rehabilitation needs could be met with home health aides or outpatient therapy instead of a skilled nursing facility, they can deny the claim. And they do. Regularly, this catches families completely off guard. They did everything right. They asked about observation status, they got formally admitted, they hit the 3-day threshold. And then Medicare still says no to the rehab facility because someone behind a desk decided the level of care wasn't medically necessary. What to do if Medicare denies coverage for a skilled nursing facility stay? You have the right to appeal. And you should. Data consistently shows that a significant percentage of Medicare denials are overturned on appeal. But most people never bother to appeal because they don't know they can, or they assume the decision is final. It's not. Get your doctor to write a detailed letter explaining why skilled nursing care is medically necessary. Not just helpful, necessary. Specific details matter. What the patient can't do independently. What complications could arise without skilled oversight. Why outpatient therapy isn't adequate. Submit the appeal within the deadline. You typically have 120 days for a first-level appeal. But don't sit on it. The sooner you file, the sooner it gets reviewed. The mistake is accepting a denial as the final word. Medicare denials are not verdicts. They are administrative decisions. and they can be reversed. The hospital admission safety protocol. Before I give you your action step, here's something you can use the next time you, or anyone you care about, walks into a hospital. I call it the hospital admission safety protocol. 7 questions. Write them down. Put them in your phone, print them out, and stick them in the folder I'm about to tell you to create. Question 1. Am I being formally admitted as an inpatient, or am I under observation status? Question 2. Can you give me a complete list of every provider who will be involved in my care today? And which of those providers are in my insurance network? Question 3. Will any of my current medications be changed or substituted during this stay? And can my own physician be consulted before any changes are made? Question 4. What are my rights if I believe I'm being discharged before I'm medically ready? Question 5. Is there anything in the paperwork I'm signing that makes me financially responsible for charges my insurance might not cover? Question 6. Can I get a copy of my discharge summary before I leave? And who do I contact if something in it is wrong? Question 7. If I need rehabilitation after this stay, what criteria does Medicare require for coverage? And is anyone tracking whether those criteria are being met? Any decent hospital patient advocate, social worker, or physician will welcome these questions. They'll respect you for asking them. And if asking them makes someone uncomfortable or makes you feel like you're being difficult, that reaction tells you everything you need to know about how carefully that institution is looking out for your interests.